In this particular section, we are going to discuss on the acute lymphoblastic leukemia, that is ALL. You already know about the epidemiology of the ALL, like how AML is important for adults. Similarly, ALL is important for children, as most of the cases of ALL is going to happen in the children only. Typically speaking, the peak age of ALL is around 3 to 7 years of age, and more than 80% of the ALL is going to happen within the first 6 years of life. So that is the reason this is the leukemia of children, we often call it as. But anyway, without wasting much time, let us move on to the ALL, because these epidemiological facts we have already seen and covered in the basics of leukemia. In acute lymphoblastic leukemia, one important thing to note is that what is the difference between an ALL of leukemic type, and you also have something called acute lymphoblastic lymphoma, that means ALL of lymphomas type or lymphomatous type. So ideally it comes from the blast count. The blasts generally tend to be more than or equal to 20% in the bone marrow, that's what I'm saying, bone marrow, in case of ALL of leukemic type, and it will be less than 20% in lymphomatous type. And lymphadenopathy you can see or may not see here, but very, very usual in case of a lymphomatous type, because lymphomas means they are going to present like a lymph node enlargement only, lymphadenopathy. And typically even some books mention they present like a mass lesion because of the lymphadenopathy. That's also true. But anyways, leukemia means, I told you already, the blast will be in the bone marrow and in the blood. Whereas it's a lymphoma means the blast will be in the lymph node predominantly, but less will be in the blood and the bone marrow. As simple as that. So this is the difference between a lymphoma and a leukemia from ALL perspective. So what is the cytochemistry? So basic cytochemistry we have discussed already. Remember, the most important cytochemistry in ALL is this TDT, terminal deoxyribosyl transferase, which is positive in almost more than 95% of the cases. Clear? Similarly, morphologically speaking, there will be no granules. Remember, this granular configuration is very important for myeloid lineage, because a lot of myeloid lineage cells will have granules, exception being a little your monocytic lineage predominantly and your undifferentiated first type, that is AML M0 without maturation, that might not have granules. Apart from that, the classic feature of any myeloid lineage, especially granulocytic precursor cell, is presence of these granules and oil rods. You know that, but here you won't have any kind of granules. And next, if you go to the immunophenotyping, because majority of the ALL are arising from precursor lymphoid cells, common lymphoid progenitor, so it will be either a pre-B ALL or a pre-T ALL. It can be a B cell lineage or a T cell lineage ALL. So first let us see what is the precursor marker. Precursor markers typically CD34 and TDT, out of which will be positive. The most important in this is the TDT, which I told you already. Then it could be either a B cell ALL or a T cell ALL, depending, and again you can find out depending on what markers they express. So very commonly they are going to express the CD19 marker, which is definitely a pan B cell marker. And then you might have the CD10 positivity, because the CD10 is also referred to as something called a KALA, which is one of the earliest markers detected for acute lymphoblastic leukemia. That's why it's called a common ALL antigen, KALA. And you have CD20, sometimes you can have CD22 sometimes, and even you can have CD79A sometimes. But the CD20 is generally rare because it's commonly seen in little bit mature B cells, so generally rare. But CD22 and CD79A, again, it's very common in case of ALL. But the most important will be the first two, that is CD79 and CD19 and the CD10. So if it's a T cell ALL, then it will be something around CD3 positivity, because this is a very important thing, because this is a pan T cell marker. This is a pan T cell marker. Then you might get CD2 positivity, then you might get CD3 positivity. Typically it will be in the cytoplasm, not in the cell surface. All these details we have seen in the basics of your lymphocytes itself. Then you have CD5 positivity sometimes, and you can have CD7 positivity. 4 and 8 usually rarely positive, because it's seen in mature T cells only, most of the times, effector T cells. So in this particularly I will see CD3 is very important. In this CD19 I will tell most important, and CD10 most important. So these are three markers that you have to know for your immunophenotyping with relates to the B cell versus the T cell. The next step is understanding the FAB classification. FAB, you know, is a morphological classification, like what we see in AML, but it will be a lot different classification here. We differentiate ALL into L1 type, L2 type and L3 morphology, L3 type. So what you are seeing in ALL of L1 type is the cells as a whole are small and homogeneous, whereas here you are seeing the cells as a whole are large and heterogeneous. You just see the gross appearance of the cells, you can make it out. And again here the cells are generally large and homogeneous. So these are the differences in the cell shape and size. The second one, you can see the cytoplasm. The cytoplasm you can see here is very scanty cytoplasm. Hardly you see any cytoplasm here. You can see maybe a little, maybe here, little, but very little. Hardly any cytoplasm you are seeing. But here you can see a reasonable amount of cytoplasm, isn't it? Reasonable amount of cytoplasm, which means it is moderately abundant. Moderately abundant cytoplasm. It's not that much, but still it's there. So that's why it's called moderately abundant cytoplasm. Then the cytoplasm is less basophilic here. You can see here also it is less basophilic. It's not that basophilic. But you can see here it is intensely basophilic. Again, you can see the image. You can see the cytoplasm is much bluer compared to the other types. So intensely basophilic. Intensely basophilic. Clear? Then this cytoplasm will also have certain vacuolization. Vacuolization can be seen in a little bit in L2 and L3 type, but very prominent vacuolization. Vacuolization you are going to see in the L3 type only. Apart from that, nucleus of L1 tend to be small, regular and homogeneous. This means small and homogeneous. But typically you will not see nucleoli that clearly in very inconspicuous nucleoli. But here nucleus is variable because it's heterogeneous. That's why it's variable and heterogeneous. At the same time, they will have a lot of irregular clefting in the nucleus. Irregular clefts will be there, and you can see a very prominent nucleoli. Here you will see a stippled, regular and homogeneous nucleus. Regular and homogeneous nucleus, but you will see a very prominent nucleoli, like what you saw here. Very prominent nucleoli you will see. Clear? So these are the differences in morphology. You can see, make out, you can visibly see in the gross picture which I have shown itself, this is a FAB L1, L2, L3 type of lymphoblast. Okay, but what is more important right now is the WHO classification more than the morphology. WHO is very well, they are going to classify based on the cytogenetic classification, where you can divide into B, precursor B LLL, that's called a pre-B LL, precursor B lymphoblastic leukemia, pre-B-ALL, or you can have something called a pre-T-ALL, precursor T acute lymphoblastic leukemia or lymphoma, pre-T-ALL. So remember, the pre-T-ALL as of overall it is extremely less common, it's only 15%, whereas pre-B-ALL is the one that is going to form the most common, 85%. Similar to what you see in lymphoma, even in lymphoma, B cell lymphoma is going to be of 85%, and T cell lymphoma is only 15%. Like that, the same applies here as well, same numbers. So there are certain types, there's no types for pre-T-ALL, but I can tell you certain types for pre-B-ALL according to cytogenetics. Number one, ALL that has Philadelphia chromosome positivity, this is called Ph positive ALL. Second one, ALL with 1123 translocation, this is nothing but MLL rearrangement. ALL with 1123 MLL rearrangement, ALL with T119 translocation, which has this TCF3 PBX1 rearrangement. TCF3 PBX1 means it also is called as E2A, and that's called elongation factor. So this with PBX1 rearrangement is also correct, but you can remember just like what TCF3 PBX1 rearrangement. Number 4, ALL with T1221, that is translocation of 1221, where you have ETV6 RUNX1. ETV6 RUNX1 translocation. Then number 5, you have hyperdiploid ALL. Typically they will have more than 50 chromosomes, hyperdiploid ALL. Then you have hypodiploid ALL. And finally you have ALL related with translocation 514. That is interleukin 3 with immunoglobulin heavy chain. 514. This 14 many times it goes with heavy chain. So that's why. So interleukin 3 with immunoglobulin heavy chain translocation. So these are the WHO cytogenetic classification. You can divide into either a pre-B-ALL with certain classical cytogenetics or a pre-T-ALL with certain cytogenetics which I have not mentioned here and not important for your exams also. For example, again cytogenetics depend on the age. Let us see. If you ask me this T1123 and MLL rearrangements, it's very common in infants. Again cytogenetics are going to be dependent on age. So this T1123 MLL rearrangements are very common in infants. Similarly, this ETV6 and RUNX1, this T1221 translocation and hyperdiploid ALL, these things predominate in children. Clear? So these are things that are going to be common in children. So remaining mutations, all these things, hyperdiploid, T514, all these things are usually seen in adults. That to remember, the incidence of Philadelphia chromosome, this incidence of Philadelphia chromosome directly proportional to the age, which means more the age, more is going to be the incidence of Philadelphia chromosome. And also remember, Philadelphia chromosome is associated with worst prognosis in ALL. Among all cytogenetic changes, if ALL is associated with Philadelphia chromosome positivity, it's going to be associated with the worst to worst prognosis, the worst prognosis, Philadelphia chromosome positivity. So, and again, if you ask me the T cell ALL, pre-T ALL, most of the pre-T ALL will be due to activation of NOT signaling pathway. I told you this NOT is very important to commitment into the T cell lineage. That's why many of the mutations in pre-T ALL will result in activation of the NOT signaling, NOT related signaling. So if you compare this B cell TLL versus pre-cell TLL, B cell ALL versus a T cell ALL, if you compare and see, what are the special features of this T cell ALL? T cell ALL, the WBC count tends to be very high. They most often tend to present with mediastinal mass, and many times they have pleural effusion. Many times they tend to have pleural effusion. So these are the three major differences, because all these are very less in incidence here. I'm not telling WBC count will be very less, but to be honest, WBC will be extremely high in case of T cell ALL compared to B cell ALL, and most of the time when ALL comes to mediastinal mass, it's supposed to be a T cell ALL, and if ALL comes with a pleural effusion, again it's supposed to be a T cell ALL. That is what the meaning of this is. It's not like what you think this will be seen only in T cell ALL. All these things can be seen in your B cell as well as T cell ALL. Clear? Now what we are going to see is on the treatment of the ALL. That's what we are going to see. If you are going to see on the treatment of the ALL, the first thing, as I told you, you have to do three things in ALL alone. So one is called induction therapy. Second one, do not forget about the CNS prophylaxis, because almost all ALL need CNS prophylaxis, because ALL, the primary sanctuary site is the brain, and CSF seeding is extremely common. So CNS prophylaxis is very important from ALL perspective, not for AML. And third thing, you have something called a post-remission treatment, which means this is like a consolidation therapy in AML. You can also call it as consolidation therapy if you want, doesn't matter. So induction therapy, you can divide into whether patient is having Philadelphia positivity or patient who is having other mutations apart from Philadelphia positivity. Remember, this Philadelphia positivity is seen in approximately 25% of the patients. Around 25% of the patients will have only Philadelphia positivity. Clear? The T922, translocation of 922, BCR-ABL translocation. So in Philadelphia positivity, you have to give chemotherapy, standard chemotherapy and a steroid. Plus at the same time, most importantly, you have to add additionally a tyrosine kinase inhibitor like imatinib, which we'll see in detail in CML, what are the tyrosine kinase inhibitors. But right now, along with chemotherapy, you have to add imatinib or any other tyrosine kinase inhibitor, which is really, really important. So in all the other mutations, what you can do is you can use certain regime. For example, if its age is less than 40 years, if age is less than 40 years, including children, you can use something called a VAD regime. I mean, I'll tell you what it is. If age is more than 40 years, especially in adults, you can use something called a hyper-VAD regimen or CVAD regime. So what do you mean by VAD regime? What do you mean by VAD regime? VAD, V stands for vincristine, A stands for asparaginase, otherwise simply you can even call it as pegylated asparaginase, and D stands for doxorubicin, and D stands for dexamethasone. Steroid is a very important component. Then you have something called a hyper CVAD regimen. What do you mean by hyper CVAD regimen? You can write, this is called hyperfractionated cyclophosphamide. So which means basically the essence is cyclophosphamide, that's what you have. Hyperphosphonated cyclophosphamide, so that's called hyper C. Then V stands for again vincristine, and A stands for an anthracycline. Anthracycline, typically I am going to use doxorubicin as usual, and D stands for dexamethasone, which means I am avoiding asparaginase in older patients, that's all, nothing else. So asparaginase will not be, asparaginase is usually used in younger patients and children, but whereas here in hyper CVAD regimen I am not using this asparaginase. This regimen will not include. So there is something called reduced intensity chemotherapy. If the patient is having even more older age like 75 years and plus, we are going to use something called a reduced intensity chemotherapy also. Then second thing which I want to tell is about the CNS prophylaxis, because in any ALL patient CNS prophylaxis is mandatory. I already told you in the basics of leukemia where I am going to give something called an intrathecal methotrexate plus probably cytarabine. You can write as Ara-C also. Probably I am going to use cytarabine, plus or minus I can give whole brain radiotherapy. That's called WBRT, that's called whole brain radiotherapy or cranial irradiation, that's what we call. But in exam commonly what they are going to ask is this intrathecal methotrexate as a very important component for like your CNS prophylaxis in many tumors, especially for ALL. Post remission therapy, again it depends on risk of the patient. I'll tell you what are the risks. Suppose if it's a standard risk or if it's a high risk. I have not told you yet what you mean by standard risk and a high risk ALL. Standard risk means I'm going to just give a consolidation therapy for 7 months. Once I give consolidation therapy, I'm going to use after that maintenance therapy, maintenance treatment for 2 to 3 years. For 2 to 3 years. So this is what you do in a standard risk. For high risk patient, I have to give extremely high dose chemotherapy. Along with that, I have to do allogenic stem cell transplant, especially once they achieved complete remission. Once these patients have achieved complete remission. Definition of complete remission here is very similar to that of what you saw in AML. In AML, I told you one of the important morphological definitions for complete remission is less than 5% of blasts in the bone marrow. Same thing applies here. Less than 5% blasts in the bone marrow will tell you the morphological definition of complete remission in ALL as well. So this is what I am going to use. And even though the treatment I have told in as simplified way as possible, but you have to know about the prognosis and risk stratification. Prognosis heavily depends on a lot of cytogenetics, as I already told you. But to be honest, let us see two things. One is called a standard risk and second one is called a high risk ALL or a poor risk ALL. Remember, according to many hematologists, there is nothing called a good risk ALL. You have to know there is nothing like a favorable risk ALL or a good risk ALL like what you saw in AML. It's all about either a standard risk or a poor risk. There is no good risk as far as ALL is concerned. But it's a common tendency that the standard risk is actually taken as a good risk feature or a good prognostic feature, but it's actually not. ALL means itself is a poor prognosis. But for exam related purposes, the standard risk you can take it as a good prognostic sign or a good marker. But again, there is no good prognostic sign. There is nothing called a good risk ALL. For exam's sake only, the standard risk can be considered as maybe a good risk. Clear? After that, you have to see the features. One important feature is the WBC count. The WBC count generally is low. If it's low, it comes under the standard risk. Typically, if it's a B cell ALL means, if it's less than 30,000, or if it's a T cell ALL means if it is less than 1 lakh. So these are all good risk. And what is poor risk? Poor risk if the WBC, total WBC count is very high. For example, if it's a B cell ALL, if it's more than 30,000, or if it's a T cell ALL and the count is more than 1 lakh. Clear? Okay. Then sex or gender of the patients. Generally, girls do well and boys do very badly. So it's a poor risk ALL. And again, age, children. Clear? Typically, more than 1 year of age, they generally tend to do very well. And again, extremes of age, less than 1 year or an adult patient with TLL, they don't do well. Clear? And again, immunophenotype, the type of the ALL also matters. Remember, B-ALL in children and T-ALL in adults, they really do well. And again, the CD10 positivity is a standard risk that is called CALA positivity. They generally do well. I mean, it's one of the good risk features or maybe standard risk features. But a B-ALL in an adult or a T-ALL in children, they do very badly. That's a poor risk. Then you have cytogenetics. Very important here again, what is a good risk and what is a poor risk? A normal cytogenetic will come under a standard risk, and a hyperdiploidy also come under a standard risk. Clear? Then your translocations like T1221 translocation, that is nothing but ETV RUNX1 translocation. Generally a decent prognosis. Any abnormal karyotype is not good, to be honest, but normal is always better than abnormal. Anyway, fine. So in poor risk, you are going to have this, the most worst I told you already, it is T922, that is Philadelphia chromosome positivity, one of the worst prognosis. Of all, if you ask worst prognosis, this Philadelphia positivity in ALL is this badass. It's worst prognostic sign. This BCI-ABL translocation ALL, not in CML. So then this MLL rearrangement, T1123, MLL rearrangement. Then you have something called hypodiploidy, that is less than 44 chromosomes. Less chromosomes than what you have is called hypodiploidy, poor prognosis. Then translocation of 119, that is also referred to as something called AML-TEL1 fusion. Clear? Not AL, AML gene is also AML-TEL1 fusion, T19. Then if you have a JAK2 mutation related AL. Remember, mutations related to JAK2 and resulting ALL will be seen in patients with Down syndrome. Like how I told you AML-M7, Down syndrome, 122 translocation, I think we have seen it. So like that here, the JAK2 mutations in ALL is associated with Down syndrome. This is a very important point again. And complex karyotype. There it is more than 3 chromosomal issues. Here it is more than 5 chromosomal issues. So the patient is having very complex, more than 5 unrelated chromosomal issues. So this is definitely a very poor prognostic sign, of which I will like you to note this hyperdiploidy, because you have hypodiploidy here. Because in exam it's very easy to set the paper. All of the following are standard risk or all of the following are poor risk, except they will give hyperdiploid or hypodiploidy. It's very easy to give the question. That's why that point is very important. But I feel the most important worst prognostic factors is Philadelphia chromosome. That definitely has to be remembered for ALL. Very poor prognostic sign. Maybe you can remember this MLL if you want, and maybe you can remember this 1221 RUNX1 ETV translocations, and maybe if you want to remember, you can remember this JAK2. That's it. So, but do not forget this. The final take home point is, don't forget this hypodiploidy and hyperdiploidy. Hyper is a good and hypo is a poor risk. I mean, again I'm telling, even though I used interchangeably the good risk with the standard risk, to be honest, there is nothing like a good risk ALL. It's always either a standard risk or a poor risk from ALL's perspective. Apart from the cytogenetics, you have other things like time to clear blasts from blood, less than 1 week or more than 1 week, standard risk and poor risk. Then time to achieve remission through chemotherapy. Time to achieve remission through chemotherapy, if it's less than 4 weeks and more than 4 weeks. If there is a CNS disease at presentation, yes or no. Yes means poor risk, no means relatively okay risk. CNS disease at presentation. Then there is something called a minimal residual disease. It's usually tested at 1 month. I told you already for AML, but here also it applies. Minimal residual disease. This is actually very important for ALL than AML. That's called MRD, minimal residual disease. So at 4 weeks, generally we check at 1 month. So if it is negative at 1 month, we'll check if it's a child. At 3 months we will check if it's for adults. At 3 months it is negative for adults, or at 1 month if it's negative for a child. That's a good risk relatively. But if minimal residual disease is still present at 3 to 6 months, at 3 to 6 months you are checking for it and still it's present, definitely it's a poor risk. So these are some of the standard prognostic indicators of ALL. And remember, the thing that they often ask you is about the female-male difference. Females have a standard risk, males have a poor risk. Then your cytogenetics, which I told you already, especially the hyper and hypodiploid and the Philadelphia chromosome part. Then they will ask you about the B-cell ALL in children do well and the T-cell ALL in adults do well, whereas it's opposite. T-cell ALL in children do badly and B-cell ALL in adults also do very badly. That one they will ask you. Apart from that, this time to clear blast, time to remission, 1 and 4 weeks cut off, and minimal residual disease at like 4 weeks and 12 weeks. That is 1 month and 3 months in children and adult respectively are absent. If it's absent, you call it as good risk, standard risk, and if it's present, you call it as a poor risk. So these are the questions they will ask you, but please do not forget this. Finally, again, one more time, the gender, the age, the phenotyping, and the cytogenetics, that to whichever I told you. So these are the 4 things that you should never forget for exams, because they are very commonly asked in exam scenarios. So what do you mean by this MRD, minimal residual disease? It's an emerging concept. It's not identified by routine techniques. It has to be identified by something called FACS. This is what we refer to something called fluorescence activated cell sorter. I'll write maybe fluorescence activated cell sorter. So this is to detect even 0.1%, that is less than 0.1% of cells, whether it's circulating or not. So even though this minimal concept of minimal disease came because even though we see the bone marrow and the blood grossly, they are cleared of blast. We are not seeing any blast in the blood and the bone marrow, but there are small amounts of, I told you in the AML itself, small amount of tumor cells, blast may still be circulating in the blood to an extent, and the bone marrow also may harbor a little bit of blast, and which still can be circulating in the blood. So take the peripheral blood and send for a FACS analysis. Even 1 or 2 cells, if they are circulating, that can be picked up by this FACS, fluorescence activated cell sorter analysis. So remember, this is a very important thing, because if MRD is present, I told you, at 3 to 6 months also, some 1 or 2 blasts are still circulating in the blood, it indicates not a very good prognosis. It's a poor risk, because even though the leukemia appears to be gone, the blasts appear to have cleared, there are some few minute microscopic blasts that are still passing in the blood, which are picking up by FACS through, and we are actually giving a name called minimal residual disease. Again, if they are circulating, it's not going to be a good sign for the child, for sure. And remember, the overall incidence is of Philadelphia chromosome, I already told you, it is approximately 20 to 30%. Typically, this Philadelphia chromosome is going to be seen in adults very, very commonly. Clear? In adults only you are going to see this Philadelphia chromosome, and the incidence of Philadelphia chromosome is going to be extremely dependent on the age as usual. So I think we have done a decent job on ALL. If you know this much is enough for ALL, but most importantly only 2 to 3 areas they will be asking you in ALL. Number 1, the markers of ALL, the CD markers, don't forget the CD marker and the TDT. I'll tell you what is important. CD markers and the TDT positivity, this is important for exam. And second one, your certain cytogenetics, important cytogenetic classification, especially you have to know what is there in children and what you see very commonly in adults and what are the cytogenetic changes in infants. So this is very important. Number 3, and the prognostic factors, risk stratification, prognostication. Typically I told you 4 points that are important. One is the sex related thing, then second one is the cytogenetics related thing, and third is the immunophenotyping, what ALL has a good risk and what has poor risk, immunophenotyping, and finally your minimal residual disease. So this could be the probable thing that you might be asked in exam. Number 4, and the treatment wise, remember that asparaginase is a main component. Remaining drugs you know, but asparaginase is a main component, especially for age less than 40. Use asparaginase as one of the main, because this is a very important drug that's used for ALL only. In AML we don't use asparaginase. And remember the regimen's name at least, that's VAD regimen, hyper CAVD regimen we have. So these are the important things. If you know these things thoroughly, and among all this, if you pick up one thing, I will tell it is the prognostication. This is going to be the most important for exam perspective. I hope we have done a decent job on ALL again. I think this is the most important things. Whatever important is there, I have told you. And with this, we are concluding the acute lymphoblastic leukemia video also. And in the next section, we will be discussing on myeloproliferative neoplasms.